This is a case on imaging appropriateness. In this instructional video, I will go through the clinical stem that has been provided to you in the case module, and I will go through the post-module quiz questions with you. So in this scenario, you are the radiology resident covering the CT service. You receive a phone call from the obstetrics and gynecology team about a 34-year-old patient who presented to their service with acute onset shortness of breath at 32 weeks and 5 days gestation. The patient endorses sharp right-sided chest pain exacerbated by deep inspiration. Her past medical history was significant for chronic kidney disease secondary to IgA nephropathy. Her vital signs on presentation demonstrate a normal temperature of 37.0, tachycardia with a pulse rate of 140, tachypnea with a respiratory rate of 20, and low oxygen saturations with 87% on room air. Pertinent laboratory investigations include an eGFR of 22, where her baseline is 47. The clinical team is asking to request a CTPE scan. The MRP tells you that they discuss the risks of radiation exposure for the fetus with the patient and that she has consented to the examination. So based on the clinical stem, as you were reading the history and seeing the vital signs, this should have already raised your suspicion for pulmonary embolism. So the fact that she has acute onset shortness of breath, she's endorsing right-sided pleuritic chest pain, she's presenting with tachycardia and low oxygen saturations. This scenario may not be uncommon if you choose to pursue radiology as a specialty, because you will be a steward of ionizing radiation, which is a resource all on its own, and is not without its risks to the patient and the fetus itself. Radiation risk to the fetus does change based on how far along the mother is in their gestation. For instance, if there is radiation exposure to the fetus early on in the pregnancy, it tends to produce an all or nothing effect. So it will either induce a spontaneous abortion, or the pregnancy will carry on without any complications. If exposure occurs in the organogenesis phase, it can result in fetal deformities. And if they are exposed later on, like this patient in their third trimester, the risks are a little bit harder to quantify. The literature does state that it could place the fetus at an increased epidemiological risk of certain cancers like leukemia, but it is hard to apply an epidemiological risk to a specific patient, but it's still important that the mother knows of this risk so that they can make an informed decision. A second issue in this stem is the fact that the patient's eGFR is quite low and significantly lower from her baseline eGFR, indicative that there is an acute kidney injury on top of a chronic process. And this becomes an issue because in order to have a CTPE scan, the patient must be administered iodinated contrast material to achieve a diagnostic image. And that leads us to question 1. So what is the risk of using iodinated contrast material on this patient? And the answer is a risk of contrast-induced nephropathy or contrast-induced acute kidney injury. A and B are not associated with iodinated contrast material, and although patients who receive iodinated contrast will experience systemic vasodilation, it is more of an expected side effect rather than an adverse effect, which is why the technologists will often inform patients that after the contrast is injected into their IV, they may feel a warming, flushing sensation. The second question is, what is the most appropriate response to the team's request for a CTPE scan? A is not the correct answer. although non-maleficence is an ethical principle, that classic phrase of do no harm that we often associate with medicine. In Canada, the ethical principle of autonomy tends to supersede a principle such as this, which leads us to the correct answer, which is have a discussion with the clinical team and the patient about possible alternative imaging modalities to answer the clinical question, such as a nuclear medicine VQ scan. So in this scenario, the team, including the patient, has to balance the benefits of having the examination, such as rapid acquisition of images and expedited treatment with anticoagulation, versus the risks to the fetus and the mother with using iodinated contrast. If the patient is aware of these pros and cons and the team feels that they understand them well, then they can make an autonomous, informed decision to proceed with the investigation. B is not correct because you wouldn't simply approve the scan based on the informed consent that was mentioned in your STEM. The MRP in the STEM only told you that they consented the patient based on radiation risks to the fetus. We have no reason to believe that the patient was informed of the risk of contrast-induced nephropathy in her case. And our cutoff values oftentimes for EGFR is 30. In her case it's 22. So at that point, that's when the team and the patient have to be contacted in order to decide to proceed with the examination. So you would not outright deny the test, you wouldn't outright approve it, you would have an informed clinical discussion with the team and the patient. And in fact, at Royal University Hospital, even if a patient has provided consent to their MRP to undergo a CT scan while pregnant, we as radiology residents or radiology staff will still go down and have a discussion with the patient to ensure that informed consent has been achieved. Question 3. What does the ALERA principle stand for? The answer is C, as low as reasonably achievable. And that means avoiding exposure to radiation that does not have a direct benefit to you, even if the dose is small. And this often involves balancing image quality with radiation safety. You want to ensure that you have a diagnostic quality image. It doesn't have to be perfect, it just has to be good enough to make the diagnosis while keeping the dose as low as reasonably achievable for the patient. If you can imagine, if you're too concerned with radiation safety, the dose may not be enough to properly penetrate the image, and you could have large amounts of artifact or quantum model that could make you unable to provide a diagnosis, and then the patient will have derived no benefit from the examination and may have to be irradiated a second time. And our last question is, what is an absolute contraindication to MRI? And the answer is B, a metallic foreign body in the eye. And this is risky for two reasons. So the strong static magnetic field in an MRI scanner can actually attract ferromagnetic objects like a metallic foreign body in the eye and actually cause them to accelerate towards the center of the machine. So in theory, a metallic foreign body could go flying out of the patient's eye. This is why technologists will screen the patient carefully before they get in the scanner, and they will always ask if the patient is a welder or has ever had a metal fragment in their eye. Another reason why it can be dangerous is because of the radio frequency field that is created by the RF coils in our MRI scanners, and that could potentially cause tissue heating, especially in ferromagnetic foreign bodies, such as metal in the eye. So it could cause the metallic foreign body to heat up and damage the surrounding delicate tissues in that region. pregnancy is not considered an absolute contraindication to imaging, and neither is diabetes mellitus type 2. And lastly, an old tattoo is not an absolute contraindication, but a tattoo that is less than 6 weeks old can be a relative contraindication, because it can actually, the MRI scanner can cause heating of the pigment in that fresh tattoo that can burn your skin. But again, that would be considered a relative contraindication and would not apply to an old tattoo. And that concludes our case on imaging appropriateness.